네, 지금부터
We will now begin Global Korea Convention 2020 K-Quarantine and Healthcare Session. I am the president of Korea Institute for Health and Social Affairs. My name is Cho Hung-sik. Let me say a few words as an opening remark. Good afternoon. We are having the 3-day Global Korea Convention 2020. We're dealing with the topic K-Quarantine and Healthcare. I am the president of KIHASA. I would like to thank the Minister of Health and Social Welfare. He was supposed to come, but instead, Mr. Ko De-kyung from the ministry is going to read his remark on the minister's behalf. I would like to thank the officials from the Ministry of Health and Welfare for coming to the conference, and also I'd like to thank the 2 speakers and the 3 discussants in advance. This year's Global Korea Convention 2020 deals with world peace, prosperity, sustainable development, and as Korea is enhancing its national image and status, the public institutions and the institutions have each implemented international cooperation projects, and this convention will be an opportunity to show their solidarity in this with Corona period. And we have discovered the social value that we have to cooperate in order to overcome the crisis. 140 Korean institutions and agencies are participating in this convention. And as one team, as Team Korea, we will be gaining a lot of insight and learn from many implications. On and offline hybrid events were planned ahead, but because of COVID-19, the 3rd wave upon us, this is a very critical moment. And so we could not have this event face to face, but we have still the online platform, and I'm sure many people are watching. Up until now, Korea has gained a lot of soft power based on its hardware capabilities, and without such learning and knowledge, we wouldn't have been able to have such an online event. It would have been nicer if people could gather together and meet face to face at the convention, but that cannot be the case this year. We're dealing with the topic of K-quarantine and healthcare in this very session. We are experiencing the 3rd wave of COVID-19. Up until now, Korea has been able to weather the COVID-19 pandemic with the K-quarantine capability, and we're known for that worldwide. 3T, testing, tracking, treatment. The process of 3T has been abided by, and this was linked to our quarantine and prevention measures in everyday life. This was thanks to the people's participation and voluntary compliance. Korea's soft power began to gain recognition, and cultural, educational, science, and technological areas, we are able to respond very well in the welfare sector, and I think we're gaining recognition worldwide. We need to re-evaluate K-quarantine and visit Korea New Deal and to become one of the active leaders in the global arena. We need to rethink Korea's role, and I hope this will be an opportunity to discuss relevant topics. Along with quarantine, there are many aspects to health and welfare related industries and public health, social insurance systems. We need to visit these issues and take a leap forward. With that, I'd like to close. Thank you very much.
그러면은
And now, from now on, it is time to listen to the congratulatory remarks. So, on behalf of the Minister Park, Director Go is going to read the minister's speech.
안녕하십니까.
Good afternoon. Hello, I am Go Tae-kyung from Ministry of Health and Welfare. I welcome you all to the Global Korea Convention 2020. I hope today's convention will be a forum for countries to share their wisdom, particularly for Korea to share its wisdom, experiences, and insight to achieve sustainability, peace, and prosperity for the global community. Minister Park was originally scheduled to be present to deliver his remarks, but as you are well aware, the COVID-19 situation is quite serious now. So there was an emergency cabinet meeting he needed to attend. So I am going to read his remarks instead. Good afternoon. This is Minister Park from Ministry of Health and Welfare. I'd like to thank Ki-hee-sa and Director Jo of Ki-hee-sa for putting together today's convention. The COVID-19 is leaving an important mark of our time. People are fighting against this infectious disease, and I'd like to express my sincere consolation for everyone who is struggling with this disease. And also, I'd like to express my heartfelt gratitude and respect to all healthcare workers and also professionals at the health organizations as well. COVID-19 has turned upside down our life. Overall, over 60 million confirmed cases are reported around the world, and 1.4 million people lost their lives to this disease. We are virtually in war against this infectious disease, and no one can be a winner. A virus does not know race, region, or national border, so it requires coalition and cooperation among countries. We need to share information, and we need to work together. And that is actually the power that the humanity can muster up against virus. This coalition is the biggest strength that the humanity can have. Korea was doing well in terms of controlling this disease, but still Korea is struggling with COVID-19. But still, thanks to the close cooperation with the international community, Korea has been able to contain the disease relatively well. And Korea actively researched about the characteristics of COVID-19, which led to the successful development of a testing kit. And also, we restricted incoming international travelers entry into Korea. Also, we implemented social distancing measures and other quarantine measures as well. The K quarantine incorporates transparency, democracy, and also it incorporates scientific innovations as well. So we are being flexible and creative in addressing the COVID-19 spread, including WHO and other international organizations and international media, have praised Korea's quarantine measures positively so far. And also, we are actively sharing our knowledge and experiences with the other countries as well. Many countries are actually inquiring us about how to contain and mitigate this disease. And we are only happy to work with the international community to fight this disease. And also WHO and G20, ASEAN, and also consulting body among China, Korea, and Japan. In these international avenues, Korea has been active in sharing what we know and also raising the awareness of this disease. We embrace inclusive multipolarism in terms of minimizing the impact from COVID-19. So we are going to continue to actively cooperate with the international community and international institutions as well. We'd like to share our experiences with countries less well positioned to deal with this challenge compared to Korea. We need to fight this together. And also in terms of vaccine development and vaccine distribution, we will pursue equity as well. We'd like to pursue international cooperation for each country's equitable access to vaccines. And also we would like to participate in many international avenues so that not just developed countries, but also developing countries and much less developed countries can also benefit from vaccines as well. Korea has been very actively participating in WHO and other international avenue, and we'd like to cooperate proactively in terms of revising any relevant international standards or guidelines. COVID-19 is leaving a big impact on our life, but at the same time, we are receiving positive news about vaccine development. So if the global community put our wisdom together and work together, we can overcome this crisis together. Thank you very much.
대단히 감사합니다.
Thank you very much. And now I would like to invite the two speakers to present. As the first speaker, we have the researcher Kim Nam-sun from Kihasa, and the topic is response to COVID-19 in 6 European countries and comparative analysis of health and medical system. Please use 18 minutes of your time. Thank you.
한국보건사연구원의 김남수입니다. 저는 이제
Hello, as introduced, I am Kim Nam-sun, and my topic is going to be COVID-19 responses and healthcare in 6 European countries. So let me begin my presentation.
예. 코로나
So COVID-19, initially Korea and other Asian countries and New Zealand, we kept a very small number of patients and death as well. So we were doing well. But at the early stage, Europe saw rapid increase in confirmed cases and death. So many people wondered whether Europe's response to COVID-19 was flawed or not. So this is the data from 6 European countries: France, Italy, Germany, UK, Sweden, and Finland. You can see an increase of the cumulative confirmed cases as well. This is fatality, which is also high. Relatively speaking, Germany and Finland show low mortality rate, but that is not the case for the other 4 European countries on the graph. So given this European situation, the UK and France, they began questioning why they are not responding well to the COVID-19 crisis. So here the commentators say that this is similar to the division between the right and the left during the World War II, which led to some defeats during the war. So some commentators drew analogy between the World War II situation and the current COVID-19 situation. So then the next question was then why did Europe experience such a division and still inadequate response, despite the fact that Europe has really leading scientists and medical professionals by any global standard. And this is Sweden as well. So Sweden's response was quite controversial. So Sweden's response was very different from other countries' measures. So was Sweden's response failure or not? The jury is still out on this. But personally, I think that in Sweden, Sweden also has their own version of CDC, and the Sweden's CDC director said that if we can go back in time, we probably would have taken stronger measures. And also, they didn't do quite so well in terms of taking care of the elderly. So I think that's the Swedish government assessment of its own response so far. So this is the death numbers in Sweden, as you can see here. So it's kind of hard to say that Sweden's unusual response was success compared to other countries, but still, Europe has a very highly developed, highly advanced healthcare system. So in terms of testing cases and gathering data and publishing the data, it's being done very well. So, and also in terms of the healthcare professionals' infection rate, the number itself might look high, but that's also because European countries are very strict and are doing well in terms of getting the data and getting medical professionals tested. So I cannot say that we cannot say that the European situation is better, but their measures against COVID-19 are not necessarily a complete failure. So then, these advanced countries in Europe, why have they not been able to respond better? They could have responded better. Then why that is not the case? Actually, coronavirus is similar to SARS and MERS. SARS and MERS have occurred in about every 10 or 15 years as a kind of cycle. Asia experienced the SARS and MERS a lot in recent cases, but that was not the European experience. Even if MERS, for example, occurred in Europe, there were only a handful of cases. So Europe actually didn't experience a wave of infectious disease in recent history. So they had a preconception that the COVID-19 is kind of Asia-specific disease. That's kind of my personal assessment. And also the new influenza experience. So it took place in 2009, 2010. At that time in Korea, we had the experience of procuring treatments such as Tamiflu and also vaccines as well. But in Europe, they had a financial crisis in 07 and 08, starting from the subprime mortgage crisis, as you remember. So after that, WHO, even though WHO set out a guideline to build a stockpile of treatment for new influenza, for example, Tamiflu, but European countries couldn't do that, didn't have enough stockpile. And so the Cochrane Group, according to Cochrane Group's review, they also said that Tamiflu effectiveness is questionable compared to its adverse effects. So back then, regarding Tamiflu, European countries were thinking, well, Tamiflu is a kind of controversial treatment, and we are now dealing with financial crisis in our hands, so we don't have much time, much money to buy Tamiflu. So that was the situation in Europe years ago. So, and also overall in Europe, the healthcare budget was cut back, and some healthcare centers were closed down as well, which led to an overall reduction in the number of hospital beds. So the healthcare infrastructure kind of weakened as well overall in Europe after the financial crisis. And next factor is China factor or globalization. So coronavirus took place, first appeared in Asia, but still we are now living in a globalized world. So for example, Italy has some commercial ties with Asian countries, including China. And also we have goods being transported across border. So this globalization had an impact on the spread of COVID-19, of course. Let me skip this slide and let me move on to the healthcare insurance, healthcare system and insurance as well. So you can see that most of the countries, European countries, have a national insurance system. So, and also, as you can see here, so Sweden, compared to the GDP, healthcare cost is high, or rather, healthcare budget is high in Sweden. Now let's take a closer look at the European response to the COVID-19. So it's been about a year now. So which one should be a priority, containment or mitigation? Containment is more appropriate at the early stage. So basically it means to prevent the disease from spreading further into other regions. But once the disease is spread into different regions, then the priority should be on mitigation. So containment is more proactive and aggressive, and mitigation is kind of a responsive measures. But that does mean that there is a clear-cut boundary between containment and mitigation. And if you look at the responses taken by most European countries, they viewed it as already widespread disease that was spread into local communities. So they were less aggressive about implementing rapid testing, for example. And here's a quote from a Finnish official here. So in the case of the Finland, they priority was to lower the curve, but the COVID-19 got spread much faster than expected. So if you look at the testing trend here or testing data here, so this doesn't mean that so this shows that eventually European countries also got hold of a lot of testing kits, and they ended up conducting a lot of tests as well. For example, Germany, Norway, and New Zealand as well. Well, although New Zealand is not a European country. But so, in a nutshell, as of now, European countries also conducted a large number of tests as well. So here, Germany was the most aggressive and proactive in terms of implementing the test. So even had a broad testing base, targeting broad segment of population. And now this is the case of France. The problem is, the problem was most acute, I'd say, in February, March, and April in Europe. So there was some confusion in terms of the response strategy, and I'd like to urge you to read this slide at your leisure. And so these are strategies that France took at the early stage back in spring. It was controversial within France itself. So all in all, there was some discrepancies country by country, but overall in European countries, they didn't have a high level of awareness about COVID-19, and also they was not too much concerned about the COVID-19 when it was taking place in Asia, and also the level of their preparedness was not that high in terms of the number of test kits that they had originally or the treatments that they had in stockpile, for example. And also in Asia, for example, in Korea, we experienced the MERS outbreak as well. So because of that, we already had a know-how to build IT infrastructure to contain and mitigate an infectious disease. But Europe didn't have such experience, so they didn't have this kind of infrastructure as well. So for example, even though in European countries, some countries try to use IT technology for contact tracing, but that was not mandatory, so it had only limited impact. And another issue was asymptomatic cases as well, or mild cases as well. So for these cases, patients are advised to isolate themselves at home usually. That's the European response. But in Korea, those asymptomatic or mild cases, they are isolated in a separate facility where medical professionals can observe their status, their health status. And also, this is the Italian case. And even within a country, depending on each province's strategy, the response effectiveness was very different. For example, in terms of the Veneto area or vis-a-vis a Lombardy area, Veneto area had a much more aggressive and proactive response. So they kept the mortality rate low despite the prevalence rate was high. But unfortunately, the Lombardy area was not like that. So in certain cases, there were a lot of rapid increase in terms of new patients, and the hospital beds were exhausted very quickly. So social lockdown was in place, and also later on, soft lockdown was in place even in Sweden as well. So the social distancing was monitored by a research center in the UK, and they gathered some indicators. So this is what they gathered, the government stringency index. So if you can see here, France, Germany, UK, Italy, all these countries that had a very strict policy. Whereas Sweden, they didn't go for a strict policy at the beginning. And also wearing a mask. In Korea, people are not resistant to wearing a mask, culturally speaking, but that is not the case in Europe. But over time, it was advised and even mandated to wear a mask in Europe as well. And according to this study, we can also take a lesson from the European cases as well. So, for example, in Germany, for Robert Koch Institute is the Germany's federal government's central institution for public health protection, and also public health. public hospital beds number twice or even triple times more than Korea. I'm talking about public hospital. So in certain cases in Europe, there are many more hospital beds available in public hospital sector. So that's what Europe is doing better than Korea. And also here, the intensive care unit as well. Germany has a lot of ICU. Why is that so? I think it's because Germany had a really severe experiences in the past, for example, 2 world wars and also economic depression as well. So because of such history, I think Germany has an ICU, a lot of ICU. So, and that actually paid off during this pandemic crisis. What about the UK and Finland? They tried very much proactively to secure enough hospital beds for COVID-19 patients. For example, in the UK, well, both UK and Finland, they secured over 10,000 hospital beds. And also, the hospitals are managed very much efficiently. And in the case of Germany, they have actually an ICU patient registration system. So you can monitor and check where there is an available ICU bed. And also, if you look at the medical staff support, in order to prevent medical professionals, frontrunners, from getting exhausted too soon, they allowed medical school students to go in and help out. And also in Germany as well, they are now trying to increase the number of doctors as well. And in France, they're now trying to increase the salary for doctors as well. So now they're setting aside a government budget for that. So many nurses and doctors actually used to protest for their low salary. Now the French government is trying to increase their salary. Now, R&D infrastructure. Korea did well in terms of dealing with the disease, but in terms of data gathering and studying the disease, I think European countries definitely have an edge. So this is my conclusion. So in the globalized world, a virus does not know a national border either. And an infectious disease outbreak can have a severe cost in terms of security, economy, etc. So we need to have a resilient and a sustainable healthcare system. And also chronic illness. Chronic illness definitely needs to be highly prioritized because of the aging population around the world. But now, on top of that, we need to think about infectious disease as well. So chronic illness and infectious disease, they both need to take top priority in public healthcare system. And European countries, even though they struggled a lot initially, but over time, their response became much better. And also in terms of the number of hospital beds, and also in terms of injecting a massive government budget, European countries became more proactive in dealing with COVID-19. So this is the summary of my presentation. So initially, due to the lack of awareness about COVID-19, Europe did not respond in a more agile manner, and yet the public health infrastructure that was built helped European countries ultimately to deal with COVID-19 better. And also, depending on the country's economic level and social cultural level, there was discrepancy country by country in terms of public healthcare system, the number of hospital beds, and the medical professional capacity as well. And overall, Europe does very well in terms of investing in hospital beds and human resources and data system and research infrastructure as well. And that is something Korea needs to learn from Europe. Thank you very much.
한 우리나라에 주는
There were a few implications for Korea.
실패한 것
So initially, Europe might appear to have failed, but Europe also showed a lot of strengths as well over time. So definitely there's something Korea can learn from Europe as well. For example, the number of beds in the public hospitals and also public healthcare professionals as well. So we need to secure these resources in Korea as well. That was lesson one, I would say. And the second, a lot of research data. European countries are doing very well in terms of gathering research data, which can bode very well for future research endeavors. And Korea is, of course, doing some research as well. And third, and also, the European countries are even raising the salary for healthcare workers and professionals. And also, the overall public healthcare management system was in place before the outbreak of the pandemic, which paid off. And also, there were some issues in Europe as well. For example, contact tracing. So contact tracing was a controversy in France. And if we are going to trace the contacts, then how much are we going to trace it? I think that's still an ongoing debate on it. So actually, Ms. Kim made a great contribution to drafting a white paper on this topic. And so the white paper is now in progress, and Ms. Kim is a big contributor to that.
우리 의과 서울
And now I'd like to invite the second speaker, Dr. Yoon Kim from Seoul National University Hospital. He's going to talk about K-quarantine must evolve. Please keep your talk to 20 minutes. Thank you. Good afternoon. I am Kim Yoon from Seoul National University Hospital, the medical school. I'm going to talk about K-quarantine. We are now faced with the third wave of COVID-19. How should we evolve K-quarantine so that we can have success in this third wave as we have succeeded in overcoming the first and second waves? The level has gone up to 2.5. This is the Myeongdong neighborhood. It is quite empty, the streets. And so social distancing was a must. The scale has risen much higher than the second wave, and we see signs of the third wave. And at this juncture, we should look back on what we have done and what were some of the problems in our past measures and talk about what we should do next. For quarantine, looking at the aim, there is social distancing and practicing personal quarantine in daily life to reduce the number of infections. And there needs to be testing and tracking so that there won't be the nth infection. And as for the confirmed cases, they should be treated according to the level and severity scores, and after they're fully treated, their case fatality should be reduced. Social distancing and testing and contact tracing and treating the patients. This is the core of COVID-19 quarantine. And so how have we done this so far, and what were some of the problems, and how should we do this? Let's first look at prevention and control. Up until now, this graph is showing the number of patients per population of 1 million. Korea is at the very bottom, and so are the other Asian countries. What this shows is that up until now, K-quarantine has been successful. If we look at the US and other European nations, we're able to reduce the number of confirmed cases. But what were we sacrificing? How could we reduce the number of confirmed cases? I would like to show you this graph. On top is Korea and the bottom shows Japan. Since the spring season, it shows the increase of the confirmed cases, and as was mentioned by Ms. Namsoon Kim, there's the Oxford Stringency Index. How strong and how stringent were the social distancing measures? As you can see, in Korea, the number of patients is low, and even then, there were stringent social distancing policies. In Japan, compared to the number of patients, the stringency was low and social distancing was much more flexible. And so Korea was very stringent. Even when there were few cases, the high level of stringent social distancing policies were in place. And is this the right way to go about it? In the US and Europe, according to this system, if there's one patient per 100,000, then that is the safest environment. And if we apply this, it is 500 cases. And when there's explosive growth in confirmed cases, it would mean 13,000 daily new cases. And so we still have a way to go until we can say that there's an explosive growth in the confirmed cases. And along with the stringent measures for social distancing, one of the other reasons we had to do this was because we could not have access to enough hospital beds. During the second wave in the summer season, there were patients and this shows the parallel social distancing measures. And what you need to look at is the situation after September 12th. It peaked for 2 weeks and the number of patients went down. And the number of patients was 135 patients per week. It was stable. If we had enough beds, then at this time, the social distancing level could have gone down from not 2, or it could have been down to just level 1. It was because the government could not secure enough beds, and so social distancing was enforced, and it was the non-regular workers and the small merchants who suffered from the stringent social distancing policies. And this shows the effect of social distancing. Apple is showing the mobility data. In Korea, since January, the amount of movement, mobility has gone down. It went down 1 notch in August, and now in the third wave, we have very little mobility. And in the US and the European countries, the government, even if it enforces stringent social distancing policies, the people still move around. The effect of quarantine is guaranteed only by the people's voluntary participation. The government has to secure enough beds and has to secure enough medical resources and staff, and then ask the people to abide by the social distancing policies. But the government has been negligent on getting the resources, but is just forcing the people to abide by the social distancing policies. So it can be evaluated that the government is passing the responsibility on to the people. And now let's look at treatment. What this shows is as of May end, Korea is compared to the other countries for simple fatality and age-adjusted fatality on the right-hand side. The reason why we have to look at the fatality adjusted by age is the fatality is higher in the elderly and lower in the younger generation. So we have to make the age adjustment. And after the age adjustment, we see that the number goes up in Korea and the number goes down in Europe. 3.9 in Spain. And if we compare the 3.3 in Korea, there is not much of a difference. And we can still confirm this in the recent data. On the x-axis shows the COVID-19 patients, and the y-axis shows the number of deaths, and the shaded area shows the fatality rate. And Korea is right about here. It's in the middle of 1% and 2%. And as you can see from the graph, the Korean fatality rate, even if we consider the number of confirmed cases, it is not that low still. And the reason is as follows. The COVID-19 patients were treated 80% of the time in the public hospitals, and only 20% were treated in the private hospitals. And so the role of the public hospitals stood out, and it was a rediscovery of the value of the public hospitals. But the public hospitals in the local areas, the veteran hospitals, the military hospitals, they are very small-scale hospitals, and they don't have enough ICUs and enough beds. Depending on the severity of the patients, where were they treated? For the critical and severe cases, they should have been treated in the ICU, but 55% of the patients could not have access to ICU and were treated in the general wards. And for moderate cases, even if they're treated in the regular hospitals, they should be treated in large hospitals with 300 beds, but 30% of them were treated in smaller hospitals. And so the smaller local hospitals in the provincial regions did not have ICUs and could not treat the severe patients, and thus the higher fatality rate. And so if we look at the Daegu situation, there was a mass infection due to Shincheonji religious group. Were there no beds? The mayor of Daegu said, we don't have enough beds in Daegu, so please treat the Daegu patients in other cities. And there were 17 people who waited for hospitalization but died at home. But at the time, in Daegu, there were general hospitals and university hospitals. And if we look at the bed utilization, looking at the first-tier general hospitals, the blue shows the bed utilization during the normal times and the ICU bed utilization. And during the February and March, the ICUs one half of the beds were empty in the first-tier general hospitals. It wasn't that the beds were not available. They were there, they were empty, but there was no system for the government to utilize and mobilize these empty beds. And the current and such situation has not changed, and this continues to this day, not much difference. And so I've said this, the level of treatment is not that low. It's around average. And the reason is there was no system to mobilize the beds. This could be the government's responsibility. And so there were patients who could not be hospitalized and they met death. And the number of patients could be higher who could not be hospitalized and died. And this is tragic. And this could happen again in the coming months. So what should we do? First, we have to have enough medical resources at the city level and at the county level. We have to form a new organization, and we have to secure enough human resources. And so we need to have speedy epidemiological investigation. And so there should be an additional 1,800 medical staff, but actually only 500 people were added to the team, and the decision was made too late. And so the decision came, but the city level and county level people still do not have up-to-date and speedy epidemiological investigation. And this shows the duration from the first symptoms to diagnosis. The longer the delay, this patient has a higher likelihood of infecting others, and this could lead to a mass infection. In June, it took only 4.2 days, but it went up to 7.6 days. And this is the duration from the first infection to the last infection in a group. If there is precise epidemiological investigation, if the people who came into contact were separated, there should be no infected cases after 14 days. If there were additional infections, that means the epidemiological investigation had some errors, and you could not isolate the suspect cases. And so there were 1/3 of the infections that were due to failure of epidemiological investigations. It used to be only 17%. And so these are the actual cases. It took 30 days, 20 days, 16 days from the first symptoms to diagnosis and the duration of infection. After 14 days, the nth infection had taken place as of December 4th. This shows how long the duration of the infection was. The initial epidemiological investigation had failed because 14 days have lapsed, and this shows that there is a correlation. And the second recommendation was to secure enough beds and enough staff. Through social distancing, we need to reduce the number of infected persons, but at the same time, we need to have higher medical capability so that even if we have a lot more patients come on, we have the skills and the resources to treat them properly. In the US and Europe, this is showing the classification of the patients depending on the number of infected cases. If there are 500 daily infected cases, and if they're hospitalized for 14 days, and if 5% of the population is severe, then we would need 350 beds. Even if we have 500 people who are infected every day, if we have 300 beds in ICUs, we wouldn't need to escalate social distancing due to shortage of beds and because patients cannot get to hospitals. Except for the pediatric patients, we have about 6,000 available beds, and 40% of them are allocated for the emergency patients. And in the ICU, we have 3,400 beds in the ICU that are available. And so if we have 500 daily new cases, we don't have to worry about the medical system collapsing. 360 beds, 10% could not be secured by the government, and the government is having the people worry about not having enough beds. We have to classify the patients, we have to calculate the number of beds needed, and we have to look at the distribution of the daily new cases. And so we have to have different scenarios of 30,000 infected cases and 100,000 infected cases. And we have to have a control tower and mobilize the resources. And we have to secure the beds at a discount at each county level and provide the compensation accordingly. So the role of the control tower is still with the Ministry of Health and Welfare, And there are designated infectious disease hospitals, but they are not doing much. And the hospitals are not designated to treat the moderate cases. And for respiratory clinics, the plan is just on the drawing board and nothing has been put into action. And so if we move according to the scenarios of the number of infected patients, in the first phase, we have to mobilize the state designated hospital beds, and second stage is 40% of the regular hospital beds, and phase 3 would be an escalation. And so depending on the number of patients, this shows the number of beds that can be secured. And we're now around 600 daily new cases, and 40% of the isolated hospitals, then we can have access to about 560 beds, and we wouldn't have a problem if the government had accepted our recommendation. So that was the bed. And for the medical staff, we need to have 1,700 more medical staff in the general wards. You need to segregate the wards, and you have to have more nursing resources, and we have to separate the ER into two different spaces so that suspect cases can come into the ER, and there needs to be control measures for the nursing homes. 40% of the deaths were from the nursing hospitals and nursing homes. And so we did recommend the government to take care of the control policies in the nursing homes. Only after 1 week has passed, we see the first symptoms, and in a week we see dozens of infected cases come out from the same nursing homes. And if we look at the patterns, these are the high-risk facilities, mid-risk facilities, and low-risk facilities. And as you can see, for 10,000 people, we see that there are a lot more infections coming from the low-risk facilities, and they're the psychiatric hospitals and nursing hospitals and nursing homes. And as of December, about 18% of the mass infection is coming from these facilities. Other than testing, the government should provide the appropriate fees, staff these facilities, and put in place control measures, and check the temperature of the residents of the nursing homes every day. Then they wouldn't have dozens of infected cases come out in a week. And one last thing I would like to say is this graph you're looking at is showing the situation in the Gyeonggi province. This shows the infected cases except for the asymptomatic patients. 7 days after the control measures are in place, you see the curve flattening, and then you see the graph going down. And so this shows that the social distancing is effective, but the government does not accept this because they don't draw such a graph. And if you include the asymptomatic patients, you see a similar pattern. And why is the number of patients increasing? Social distancing may be effective, but sometimes the measures are not abided by, epidemiological investigation is not done properly, and mass infection is not controlled, and that's why this is increasing the number of patients. The government should not depend too much on social distancing, place the responsibility of quarantine not only on the people, secure enough beds, secure enough staff, secure enough control policies in the high-risk facilities, and a daily infection case of 500 is too low. Increase the capability of the medical treatment first so that there is a balance of daily quarantine and government measures. Then we can have quality of life. Thank you very much. Thank you for the explanation, and I do not need to add comments or summarize. Having listened to the two presentations, I would like to ask the two speakers and the three discussants up to the stage.
예, 그
Okay, so to start off the panel discussion, we need to finish by 3:30, so we have about 30 minutes sharp. So I'd like to ask our discussants and also our presenters as well. Please limit your remarks to 7 minutes. Designated discussants, please keep your comment within 7 minutes. And you have a list of the names of the discussants on the convention brochure. So let's start with Mr. Yoon Kang-jae from Kihasa. So please finish within 7 minutes. Set a great example. Thank you. Hello, as introduced, I'm from Kihasa. My name is Kang-jae Yoon. Thank you very much for all your great presentations. And Professor Kim gave us a lot of feedback about Korea's response. So I think that was a really great feedback. And we also listened to the European response as well. So I believe that the two presentations will lay the foundation for better response measures in Korea. Today's convention is not about policy advising, so I'd like to just freely share my thoughts. So Professor Kim gave us 4 main points, and I agree with most of the points. And it's a shame that we don't have more time to discuss his presentation.
라는 의미에서
And so to flesh out his ideas, I'd like to say a few words. As for securing more staff, I do agree in principle. For example, epidemiological investigators, we have many, but quantitative growth is one matter. How should they train? How should they be trained? And how can we have quality investigators? That is a homework to be solved. And I think the government needs to put some thought into this. And maybe in the interest of time, there was mention of public health centers in the presentation material. Well, this is part of the medical service delivery system, and I think we should pay more attention to what role the public health centers should play. And you talked about 1,800 people, and there are 2,500 public health centers, so we would be having 7 more additional staff in each public health centers. And so what should the org chart look like for each public health centers? We saw this in the first wave, and when there was mass infection, everyone was assigned to the selective screening centers, and other care services were put to a halt. So how should the public health centers respond in a serious pandemic situation, I think we need to give it some thought. And for the system mobilizing the human resources and the beds, as you're well aware, well, the word mobilize and secure came up, but we have more private hospitals than public hospitals, and how to mobilize the private resources would be difficult. There was mention of respiratory clinics. If it's a first tier clinic, it's difficult to segregate into different quarters. And so how should we have the COVID-19 proof respiratory clinics? And so I think maybe with the limited resources, we're able to operate the resources. But other than the operation aspect, maybe as Professor Kim said, we should have more quantity, and I think investment needs to be made. And you talked about the living treatment centers. For mild cases, they're in the living treatment centers where they self-isolate them at home. I think primary medical care is not playing its due role. So living treatment centers and the self-isolation and the primary clinics should be connected, and they should be supplied with the ICT technology. And the mild cases are treated usually in their neighborhood, and there should be a follow-up measure. So maybe the primary healthcare facilities can be dedicated to treating the mild cases. And as for the vulnerable facilities, not only the nursing homes, we do see a lot of vulnerabilities, not just health and welfare. And as was mentioned by the professor, economically vulnerable non-regular workers, platform workers, are hard hit. And because their income is unstable, the social safety net should come into play, but it is not targeting the right people. And so sickness benefits in the European countries helped, I think. And so yes, I do agree that K-quarantine should evolve, but not only in terms of the medical aspect, but we need to evolve in terms of the social safety net. And that is talking about the human New Deal. And so we need some growth in other industries to enforce the social safety net. And we are compensating the healthcare sector, but we do need to see some progress in the social safety net to have balanced K-quarantine. Thank you.
And next, from Korea Institute of Healthcare and Public Health, Dr. Kim. Hello, as introduced, I am Soo-kyung Kim. I mostly analyze patient safety and also medical facility or hospital assessment as well. So I participated in Dr. Kim's study into European responses to COVID-19. I think that's why I am here today. So decentralization was a big theme in European countries. But the European system also revealed to have some weaknesses in terms of responding to COVID-19 at the initial stage. So I think Dr. Kim's study was very timely, and she pointed out what could be better in terms of the European response. She looked at European response to COVID-19 at the regional level and at each country's level as well. She also highlighted the differences among countries as well. And also, she put forward some ideas as to how to respond to COVID-19, including international cooperation. And containment or quarantine and treatment, and all these measures need to take place with great coordination between the central command tower and regional medical facilities. That's how I read her study. And also, a country's response to COVID-19 incorporates the society's culture and overall awareness about the disease. So, for example, mesh bus screening and contact tracing and wearing a mask. So mesh bus screening was questioned a lot in certain European countries, for example, in Sweden. And IT-based contact tracing, that was controversial, particularly in France, because of privacy infringement issues. So that's a difference between European countries and Korea. In terms of the acceptance of using IT technology to trace contacts, in Korea, we didn't have much resistance from the public, but there was resistance in Europe. So even among experts in Europe, they advised paper record first. And so in terms of the perception gap or cultural gap, aside from these cultural issues, other physical, practical, logistical issues, for example, procuring testing kit and other necessary equipment, that was an important factor. For example, Finland, they rely on import for these equipments and materials. So they had a lot of stockpile in advance, so that helped. And also, in Italy and the UK, things got more severe compared to a country such as Germany. So Germany, they procured more resources in advance, which paid off really in this pandemic crisis. And I think Professor Kim also touched upon securing enough materials and equipment for this. In Europe, many people are talking about COVID-19 fatigue. So, for example, there is an increase in the portion of COVID-19 patients in the ICU part. So the medical professionals are getting tired. They're experiencing COVID-19 fatigue. And there may be other kind of infectious disease even after we overcome COVID-19. So so Europe seems to take this as an opportunity to prepare and to improve upon their response to infectious disease. But we also have great news. For example, vaccine developments, and the vaccines are being approved in Europe as well. Vaccine is a key factor for us to go back to our normal life. Now in the UK, a vaccine usage is approved, and now they already are confirming which demographic segment will be prioritized in terms of getting vaccinated. And they're also having discussion about building necessary facility. And for treatment options as well, some options are now in clinical stage 1 to 3. So if the approval is put on fast track, then it can speed up the treatment availability as well. But it cannot be too expensive. It should be still affordable. So I think necessary data is being compiled as well. We are also involved in HD Society and other international forum, and we are having active discussion on these as well. And Professor Kim gave us a very detailed talks about this. For example, how to mobilize hospital beds. Well, I think we need to provide monetary compensation, but do we have enough budget for that? So that will be my concern. Most importantly, in my view, we need to build not just the hardware system, but also software as well. Software, I mean how to operate the hardware once we have them in place. For example, various guidelines. And also in terms of the quality of healthcare services, a lot of international gatherings are now talking about the safety concerns for medical professionals at the front line. So actually, the front runner medical professionals, their safety is a big concern because they're the one who deals with patients on the front line. And lastly, Korea did well initially in containing COVID-19 because we had a great IT technology, and also we had a isolation center for patients, and also we even isolated mild cases as well separately. So that was a great precautionary measure, I believe. And we also prepared, we also need to further fine tune our guidelines for mild cases and other cases as well. And also patient-reported outcome or patient-reported indicators. So these data can be utilized as a useful indicator. So, and also these kind of data can be utilized for approvals for health authorities like FDA. And also personal decision making needs to be supported by relevant data and by ICT. So we need, Korea did very well in terms of using IT and also the public participation in containing and mitigating an infectious disease is very important. So to do that, we need public cooperation as well.
지적된 쭉 해주신 게 한.
Yes, you pointed out 8 issues. Dr. Namsoon Kim, please address the points raised by Dr. Soo-kyung Kim. And the last discussant is a very busy professor. We have Professor Ji-hyuk Park from Dongguk University Medical School, and he wears many hats. And so I think he has a lot of first-hand experience. And so could you add more flavor to our discussion? Yes, I am Ji-hyuk Park. I was the epidemiological investigator at Korea Disease Center at KCDC, and I have also worked in many hospitals, and I was in the front line responding to the pandemic. If I had more time, I would have talked more about the merits, but in the interest of time, I will skip the advantages. The impression that I got was we're doing well in the short term, but I think it is time that we transition to a long-term response. Back in 2015, when we had the MERS outbreak, our response was a failure, and after that, there were a lot of changes. there was a lot of learning. So in the response to COVID-19, we were better compared to the other countries. And as Dr. Kim Yoon mentioned, the recommendations have not been accepted. I hope that the third wave will provide the government with the opportunity to accept the recommendations. The core of the quarantine measures, I think, is the public health centers. When we look at the cases, it is mostly at the public health center level that is at the front line. So training the professionals at public health centers is very important. And so the provincial offices, they dispatch people to train people at the public health centers. But what is challenging is the person who is responsible for the infectious disease. Well, nobody wants that job because it's difficult, you're not paid well. And to be frank, in July, when there was appointment of public servants, there was a lot of concern. The people just rotate. The people are tired, they burn out, and so uh, there's no learning curve, and there is not enough time for them to accumulate expertise. And there was a similar warning made about the fatigue issue. And so there is fatigue and burnout, but there is no response measure to make up for the loss of professionals. And after the infectious disease is done, what will these professionals do? Then you can say the same thing about the firefighters. If there's no fire, will they be sitting idle? So people think that if there are too many people in the public health centers, then they won't be doing much. But I think they're the ones who can come up with the basic data. Why don't we have the research data coming from the COVID-19? With just the few resources that we have in the public health centers, we cannot get the basic data. But if we staff more people at the public health centers, then we can have more precise basic data about the cases. And what is frustrating in the public health centers is they don't know how to form the emergency organization, and there's no training. So it should be the head of the public health centers who designs the organization in emergency situations, but he's not resident at the center. He goes out somewhere to make a report. Let's say the commissioner of the Korea Disease Control Agency is out there reporting to the president, and that's what's happening at the public health centers. If there's an emergency, the head of the center should be making the decision, but he's absent because he's somewhere making a report. So I think some of these processes should be improved. And as for the status and the statutory roles that the public health centers can play, when I visited one region, I mentioned that you should ask for public officials in other county offices and city offices because you don't have enough resources to do the work at the public health center. But according to the law, the head of the public health center does not have the authority to ask for more resources. Public health centers are very unique in Korea. We don't have similar organizations in other countries, and we are proud of having such an organization, but there are so many limitations. And there's a lot of work to be done. The people who are dedicated for epidemiological investigation has risen from 30 to 300, but the person in charge has not changed. We have a model in Korea. in order to secure beds or secure enough staff, we have this budget shortage. And I think if there is a need, we could get the budget support from the central agency. In order to have a speedy response, I think there should be some budget support. And as for the personal quarantine measures, we have very good facial masks. In February and March, we used we're using dental masks now. And so what quality masks should we be using? We could get the basic data from the public health centers, but we cannot ask them for the data. Similar things are being done in Germany, so we should dedicate resources for research. Otherwise, we cannot have data. And masks should be supported, some people say. Yes, it could be supported as a form of disaster relief. You could provide people with subsidies to purchase quality masks instead of just asking people to wear masks. And I'm surprised watching the news. Some programs show people not wearing the masks properly, and this is giving out a wrong message to the people. And so the media should be precise about the mask protocol. And as for the vaccines, if the vaccine is distributed, there could be an increase in the confirmed cases because people will be wearing masks less. And so the message of wearing the right mask properly should be disseminated. Otherwise, even with the vaccines, I think there could be an increase in the number of infected cases. Thank you very much.
아주 생생한
So we were able to listen to a really vivid first-hand experience from Professor Park. We've listened to from all designated discussants. Now it is our speaker's turn to respond. We will start with Professor Kim, followed by Ms. Kim.
Thank you for your helpful comments. I do agree with most of the comments, and I just have two things that I want to share with you. One is about the beds, and two is about the epidemiological investigators centered around the public health centers. It's not the shortage of beds that is a problem. There are beds available. The government cannot effectively mobilize the beds. The hospitals do not want to accept the COVID-19 patients, and instead they treat the lucrative patients, and they're not releasing their beds. What should the government do? For the first year, general hospitals and national university hospitals, they should release 10% of their available beds. And if the hospitals do not comply, they should be delisted from the top-tier general hospitals. 1.5 trillion won is paid more to these top-tier general hospitals, even if it's for treating the same disease. They want to hold on to their beds, and they're being selfish, and we cannot provide them with 1.5 trillion won more. If the government cannot exercise this, then it means that the government is powerless to defend the people's health rights. And as for the public health centers, yes, their rules should be enforced. And as was mentioned by Professor Park, Yes, the people working at the public health centers should be able to collect data so that it can be used in actual disease prevention and control. And so, if you were to draw the curve from the first symptom to the first infection, we wouldn't have had to escalate the social distancing. We could have found other factors, and the government could have come up with other measures. And if you just looked at the number of infected cases and if you escalate the social distancing measures, then the government is working off of no data, and it shows that there are less resources than needed. Thank you, Dr. Kim Namsu.
상황을
Yes, I reviewed the European situation. So if I can sum it up again, as Dr. Kim mentioned, so I think it boils down to the enough procurement of hospital beds and data, R&D, and medical professionals. So although they were not highly prepared initially, which led to a rapid increase of confirmed cases initially, but still they're doing well. So that's what I want to focus on. So the number of ICU beds. For that, the European government definitely secured enough number of ICU beds. They also have a public hospital system where a lot of ICU beds are available for a situation like this. And in terms of human resources as well, of course, there's a limitation in Europe as well. But Europe took a lot of care to manage human resources. So, for example, in Germany, they allowed medical students to come out and help out in terms of data entry type of jobs. So they managed human resources quite well, and they also made a lot of investment in the human resources as well. And lastly, in terms of R&D, Dr. Kim mentioned that Korea is kind of lacking in terms of R&D and data accumulation and record keeping. But in Europe, they have accumulated a lot of data, and they are even very close to developing COVID-19 indicators based on their data as well. And they're active in R&D as well. And of course, Korea is proud of what it's been doing so far in terms of response to COVID-19, but still we have a lot to learn from European countries as well. And as just as Professor Kim mentioned earlier, I believe that we also need to take the lessons, our lessons from Europe, and incorporate that into our policy. Thank you very much. So today we talked about K-quarantine in the face of the third wave of COVID-19, and we discussed the pending issues, and we talked about how to deal with the current wave of COVID-19. And we even listened to the European experiences as well. So although Europe didn't respond well initially, but over time, Europe really stepped up and did a great job. And also their infrastructure in terms of the hospitals and the human resources was a key factor. And now we are hearing about news on vaccine development. So going forward, we need to have quality data to further our research. And also, more immediately, what we need is, just as Professor Yoon Kim mentioned, we need to have a more hospital beds, approximately 10% more at national university hospitals. So we need to increase the number of hospital beds. That's a more urgent need that Korea needs to address. And also in Korea, the neighborhood healthcare center, that is kind of a backbone of the public healthcare system in Korea. And a lot is really lacking at a neighborhood or local healthcare center. So, for example, we need to dispatch medical professionals more to local healthcare center. And social distancing. We need to think about why there is a surge in the confirmed cases. So epidemiologists can hopefully identify when we can tighten our social distancing measures in order to prevent the number from going up further. So all these need to be connected well. So this is also not just about quarantine measures. Treatment measures need to be in place. Data needs to be accumulated, which can facilitate academic research into COVID-19. So all in all, well, we talk about Green New Deal. Maybe we can also think about Healthcare New Deal as well in light of this new infectious disease. So it's now time to close, but if any one of us has a burning comment that you want to make, I think I can accommodate one person. No? Okay? Okay. Okay, please keep your remark within 1 minute. I think you just summed up our session very well. And we here emphasize the need of R&D. In Korea, most of the R&D goes into new drug development and vaccine development. These are important, of course, no doubt. But we also need to have more R&D about COVID-19. And also, we need to think about the issue of fairness. And also, we need to think about the quality of medical care, medical services. So I hope that we need more R&D support targeting COVID-19. Thank you very much. So we've been here for about an hour and a half. So it was a short session, but it was very intense discussion we had. And I think it was a very substantial discussion we had. We have a representative from the Ministry of Health and Welfare here. So I hope that you can take our discussion point back to your ministry so that we can have a better policy and we can address the current wave much better. Once again, thank you all very much for your presentations and comments. So this will conclude the current session, K-Quarantine and Healthcare. Thank you very much.